Hi, it's 3 o'clock in the morning and the emergency department calls. Doctor, there is a 16-year-old girl who cannot move her legs. What is the first thing you will be doing? Is it sending her to the MRI, a blood test, or even thinking about the diagnosis first? What is the very first thing you will be doing? Paraplegia is weakness or paralysis affecting both lower limbs, usually resulting from a lesion involving spinal cord or its motor pathway. It's not a diagnosis, actually, it's a clinical presentation. Most of us immediately start thinking of diseases: transverse myelitis, multiple sclerosis, spinal cord compression, but neurologists think differently. The first question isn't what's the diagnosis, it's where is the lesion. Today, I will show you a simple mental map that helps answer that question. This is the mental map, and we'll go through each step. Step number 1. Our first question is simple. Are we dealing with an upper motor neuron lesion or a lower motor neuron lesion? Because that single decision immediately removes half of our differential diagnosis. Hyperreflexia, spasticity, Babinski sign, these point toward an upper motor neuron lesion. Flaccidity, reduced reflexes, muscle wasting, these suggest a lower motor neuron lesion. Our patient has hyperreflexia, so we are already thinking above anterior horn cell. Second step. Is there a sensory level? The patient tells us, I can't feel anything below my nipple, and as it's shown in the diagram, nipple is T4. That is one of the strongest clues in neurology. A sensory level immediately points toward the spinal cord. Then I ask one more question. Is bladder function affected? Weak legs plus urinary retention. Now, spinal cord involvement becomes much more likely. And finally, time. Is the onset acute? Is it subacute or chronic? Meaning, minutes, think vascular. Hours to days, think inflammation. Months, think compression or even tumor. Before we have ordered a single investigation, we have already narrowed the problem. At this point, you might ask, why does the examination tells us the lesion is in the spinal cord? The answer lies in just 3 major pathways. If you understand these 3, the neurological examination suddenly makes sense. First, the corticospinal tract. Think of this as the motor highway. It carries movement commands from the brain to the muscles. These fibers cross or decussate in the medulla before descending through the spinal cord. So once we are in the spinal cord, a lesion causes weakness with upper motor neuron signs below the lesion. That's exactly why our patient has hyperreflexia and a positive Babinski sign. Next are the dorsal columns. These carry vibration, proprioception, and fine touch. Unlike motor pathway, they travel up the spinal cord on the same side, only cross later in the medulla. Damage here causes loss of vibration and position sense below the lesion. Finally, the spinothalamic tract. This pathway carries pain and temperature. Unlike other pathways, it crosses almost immediately after entering the spinal cord. That's why pain and temperature loss often appears on the opposite side of the lesion. So if you can touch your nose with your eyes closed, think your dorsal column. So let's reverse our thinking. Imagine having a lesion on the nipple level, which is the T4. So regarding the sensation loss, it will be from T4 and below, contralaterally, 2 segments below, regarding pain and temperature, while ipsilaterally for vibration and pressure sensation. Notice something, we didn't memorize anatomy, we learned why the examination works. So let's go back and apply the mental map on the case. The patient had hyperreflexia, which means it's an upper motor neuron lesion, and the sensory level was at T4, meaning the nipple, so that means it's a spinal cord lesion. There was urinary retention, so definitely spinal cord lesion, and the onset was acute, so it's an inflammatory process. Only now we ask, what diseases fit this pattern? One important possibility is acute transverse myelitis. Let's move to the second patient. Now watch what changes. The localization is exactly the same, but the patient has a previous episode of optic neuritis and other neurological event. Localization stays the same, history changes the diagnosis here. Now multiple sclerosis moves to the top of the differential. Let's go to the third patient. Again, the localization points us to the spinal cord, but the patient had bariatric surgery, meaning malabsorption. That single detail changes our thinking. Now vitamin B12 deficiency becomes a likely explanation. So to summarize, 3 patients, 1 symptom, three differential diagnoses that are completely different, but the method never changed. Going back to the 16-year-old girl, at the beginning of the session, we were tempted to guess the diagnosis. Now we don't have to guess it, we have a mental map. To finish, the next time a patient suddenly cannot move their legs, don't ask what's the diagnosis. Ask where is the lesion. Because in neurology, localization comes before diagnosis. Let's imagine we meet a patient with low back pain and foot drop. If we jump straight to a diagnosis, we might immediately think this is a lumbar disc prolapse. So we order an MRI of the lumbar spine. The MRI shows a disc prolapse. At first, that seems to confirm our diagnosis, but here is the catch. Not every abnormal MRI explains the patient's symptom. In this case, we looked in the wrong place, so we found the wrong explanation, which will lead us to the wrong treatment. Meanwhile, if we think like a detective, we start by examination and correct localization, just as the mental map. Hence, we will be ordering MRI of the thoracic spine specifically, which will lead us to the true diagnosis and hence the true treatment. We are trying to treat the patient himself, while the first path was treating the MRI only. After localization and diagnosis, treatment focuses on two aspects: comprehensive supportive care like skin care, bladder care, bowel care, etc., and the management of the underlying cause and its complications. For any patient who cannot move their limbs, like bed sores, DVT, bowel and bladder incontinence, etc. Okay, to summarize, paraplegia is mainly caused by spinal cord, mainly the dorsal. Localization of the site of the lesion can be made by detecting motor, reflexes, sensory and autonomic level, and the treatment is directed to the underlying cause and supportive care. So the next time you are faced with a patient who cannot move their legs, resist the urge to jump directly to the diagnosis. Start by localizing the lesion, because in neurology, diagnoses aren't guessed, they are reasoned. And thank you. This PowerPoint was presented by Dr. Rawan Mohammed Hamoud.